Welcome to today's program titled Differential Diagnosis of Spindle Cell Sarcomas, including Leiomyosarcoma. During today's presentation, attendees will be in listen-only mode. At the conclusion of the formal presentation, we will conduct a question and answer session. For those of you who are logged into the web presentation, you are encouraged to submit questions throughout the conference by selecting the chat pod located in the lower left corner of your screen, then type and send your question. Handouts may be downloaded by going to the conference materials pod on the left-hand side of your screen. There will be a short evaluation following the webinar. We would appreciate it if you could take a minute to fill it out. If you have technical problems during the program, please contact the Beacon Live moderator by typing your question in the chat box in the lower left corner of the screen, or you can call the help desk at 877-297-2901. I would now like to introduce our speaker, Dr. Hornick. You may begin.
Thank you so much for participating in this webinar. Today we're going to be discussing the differential diagnosis of spindle cell sarcomas, including leiomyosarcoma. And I'm hoping that at the close of this session, you will have a very good sense of how to approach the diagnosis of the most common forms of spindle cell sarcomas, as well as some of the less common variants. I have no conflicts of interest. Spindle cell sarcomas include several of the most common types of soft tissue sarcoma, namely leiomyosarcoma, monophasic synovial sarcoma, and malignant peripheral nerve sheath tumor. Spindle cell sarcomas also include much more rare types of soft tissue sarcomas, which we're not going to talk about in as much detail as the common spindle cell sarcomas. I'm really going to focus on these when we're talking about differential diagnosis. Importantly, it's really critical to separate spindle cell sarcomas from benign spindle cell tumors and locally aggressive spindle cell tumors. On the left side of this table, you see some of the relatively common benign spindle cell tumors that can be quite easily mistaken for spindle cell sarcomas, and I'm going to talk about some of these in terms of differential diagnosis. And also on the right side, you see listed desmoid fibromatosis, which although it is not a sarcoma, it's a tumor type that is often treated by experts in sarcoma, both surgical oncologists and sometimes medical oncologists. And we're going to focus quite a bit on desmoid fibromatosis early in this session. So why is it important to classify sarcomas properly? There's a couple of really critical reasons. One is to avoid inappropriately aggressive treatment of benign soft tissue tumors, which I alluded to just a moment ago. And at the same time, we want to avoid undertreating sarcomas if a diagnosis of sarcoma is mistakenly called a benign neoplasm. Importantly, different types of spindle cell sarcomas show marked differences in prognosis, metastatic potential, and clinical behavior. And at the same time, there has been recent approval of sarcoma subtype-specific systemic therapies, for example, trabectedin for leiomyosarcomas and liposarcomas. So in terms of approach to diagnosis, I've just listed here a couple of really key points to think about. It's important to be aware of the relative incidence of the various spindle cell tumors. This can be so helpful. Even before you look closely at the lesion, you can have a pretty good sense of what the most likely diagnosis might be. It's important to have a knowledge of the anatomic distribution, typical depth of spindle cell tumors. Pay careful attention to histologic features. As I'm going to emphasize throughout the hour, in each of these tumor types, there's several histologic features that can be so helpful to come to a specific diagnosis. And then I hope I'm going to convince you that when we apply immunohistochemistry, we can do so in a judicious fashion, really focusing on what question we want to answer in terms of our differential diagnosis. And finally, in some cases, it's important to apply molecular genetic techniques. But in terms of spindle cell sarcomas, really the only circumstance in which that is often the case is in order to confirm the diagnosis of monophasic synovial sarcoma, as we'll talk about throughout the session. So as I mentioned, I'm going to begin by focusing on a few tumors that are not exactly sarcomas, but that can be easily mistaken for spindle cell sarcomas. We're going to start off with a discussion of desmoid type fibromatosis. This is a relatively common tumor that typically arises in young to middle-aged adults. Desmoid fibromatosis was first recognized in the abdominal wall. That's a very classic location for this tumor type, and in that setting, it sometimes arises following abdominal surgery, for example, following cesarean section. However, desmoid fibromatosis can also arise at a pretty broad range of anatomic sites, intra-abdominal locations such as the mesentery of the small intestine, or at a pretty broad range of extra-abdominal sites, and I've just listed a few of the most common on this slide. When you encounter a desmoid tumor in the mesentery of the small intestine in a young patient, in a teenager or young adult, you have to at least raise the possibility of familial adenomatous polyposis, FAP syndrome. Some cases, desmoid tumors can be the sentinel lesion that allows the clinical team to recognize that the patient has FAP. Desmoid tumors typically arise as slow-growing, painless, infiltrative, poorly circumscribed masses. Although desmoid tumors can be locally aggressive, unfortunately in recent decades we've come to realize that margin status does not correlate well with recurrence. This is really quite different from the sarcomas that we're going to talk about in this session. In some cases, very wide margins, a patient can still have a local recurrence of a desmoid tumor, and at the same time in some patients when you have an intralesional or marginal resection, the desmoid tumor does not recur clinically. So we really have moved to a pretty new approach to these tumors in terms of surgical oncology. Many experts in treating patients with desmoid fibromatosis are now taking a much more conservative approach, a watchful waiting approach. If a patient is asymptomatic and the tumor is not impinging on vital structures, in many cases surgery will actually be avoided and the patient will simply be followed. So what are the key histologic features of desmoid fibromatosis? With each of these tumors, I'm going to give you just a very short bulleted list of the key features that soft tissue pathologists like to talk about when they're discussing these tumors. Desmoid fibromatosis is characterized by very long sweeping fascicles. Often the fascicles are evident even from low power as going all the way across the slide. The tumor cells are uniform and bland myofibroblastic spindle cells that often have indistinct or very delicate small nucleoli. There is often prominent stromal collagen, and a very helpful clue to the diagnosis, which is quite different from spindle cell sarcomas, is the presence of relatively thick-walled blood vessels between the fascicles, and I'll show you an example in a moment. Often these blood vessels are surrounded by a very delicate layer of perivascular edema. Here's an example of desmoid fibromatosis just to show you how infiltrative these tumors can be. You can see at the edge of the lesion in this case how the tumor is infiltrating among all of the skeletal muscle fibers. When you look a bit more closely at the tumor, you can now appreciate this long fascicle that's going across the slide diagonally. The tumor cells are very bland and uniform. Here's another example of desmoid type fibromatosis with these very nice, delicate spindle cells arranged in these long sweeping fascicles. And I think in this field you can nicely see an example of one of these relatively thick-walled blood vessels between the fascicles. Again, that's a very distinctive feature of desmoid fibromatosis. And when you look more carefully, we can now see this layer of perivascular edema, which is not always present in desmoid fibromatosis, but it's a very helpful diagnostic clue. At this magnification, we can also see the very fine chromatin of these elongated spindle cells with tapering nuclei, indistinct cytoplasm, and this is another nice example of the prominent stromal collagen between the nuclei. Just a few more images. Here we have another example of desmoid fibromatosis. In this case, you can see these small nucleoli. In some cases, the nucleoli are readily apparent, but importantly, there's no nuclear atypia or pleomorphism in desmoid fibromatosis, although you can find mitotic activity. So what is the best diagnostic marker for desmoid tumors? I'm sure that many of you are familiar with this marker, that is beta-catenin. This is the protein product of a gene known as CTNNB1. This is a gene that's involved in the Wnt signaling pathway along with APC, adenomatous polyposis coli. And in fact, mutations in the gene that encode beta-catenin are found in very close to 100% of sporadic desmoid tumors. This is remarkably analogous to tumors that arise in patients with familial adenomatous polyposis, in which the tumor is caused by germline APC mutations. So although two different genes are involved, they have the same functional consequence. By immunohistochemistry, desmoid tumors show an abnormal staining pattern for beta-catenin, that is a nuclear pattern. Normally, beta-catenin is a cell membrane-associated protein. So this abnormal pattern of beta-catenin can be very helpful to support the diagnosis of desmoid fibromatosis, especially when you're dealing with small biopsies, a core needle biopsy, for example, or when you're struggling to decide if you're dealing with recurrent desmoid tumor versus a scar. Unfortunately, beta-catenin is not a perfect diagnostic marker. It has moderate sensitivity and specificity for desmoid fibromatosis. We do find nuclear staining in about 90% of desmoid tumors overall, and it's negative in many other spindle cell tumors you might consider in the differential diagnosis, but you can find nuclear staining for beta-catenin in some other fibroblastic or myofibroblastic tumors, and I've just listed two of them here. Low-grade myofibroblastic sarcoma is a quite rare spindle cell sarcoma that can have some overlap histologically with desmoid fibromatosis, but this tumor has true nuclear atypia and some sometimes subtle pleomorphism. So given the fact that the specificity and sensitivity are not perfect, beta-catenin must be interpreted carefully in the context of morphology, and a lack of nuclear staining does not preclude the diagnosis of desmoid fibromatosis. Here's really the perfect example. Speakers always like to show a really nice photogenic example of immunohistochemistry for beta-catenin. In some cases, the nuclear staining is not quite as prominent as you see in this field. You have to look under high magnification. If you find an area with very convincing nuclear staining, even if it's quite subtle, that is still good supportive evidence for the diagnosis of desmoid fibromatosis. So as we go through the differential diagnosis, I'm not going to go through these tables in so much detail over this hour. I hope you can refer back to these. They'll be available for you later as your handout. I'm just going to focus on a couple of key points over the course of the lecture. The differential diagnosis for desmoid fibromatosis, as we mentioned, can include a scar tissue because desmoid tumors look very much like scar. But a very interesting differential diagnosis is that of nodular fasciitis. It's quite common for desmoid fibromatosis when it arises in the abdominal cavity, especially the mesentery, to show a much more loose myxoid matrix, as you see in this example. In these cases, the tumor can very closely mimic a reactive myofibroblastic proliferation, for example, following perforation, and it can look really similar to nodular fasciitis. In these differential diagnostic considerations, finding nuclear staining for beta-catenin is very helpful to confirm the diagnosis of desmoid fibromatosis. Just a few other quick images of nodular fasciitis. In contrast to desmoid fibromatosis, nodular fasciitis is usually characterized by a much more loose proliferation of spindle cells. You find these areas of myxoid stroma and little microcysts. As you look more closely, you find little areas where the mucin or the myxoid matrix is beginning to accumulate, and the tumor cells just lack that very uniform fascicular architecture as we saw in the previous examples of desmoid fibromatosis. It's very common for nodular fasciitis to show these these stellate-shaped nuclei. Again, they're much less organized than the very organized fascicles of desmoid fibromatosis. We find these extravasated erythrocytes. That's a very typical feature of nodular fasciitis. And often it looks like that the tumor cells are being pulled apart from either end, that very loose, characteristic tissue culture-like appearance that people love to talk about as very typical of nodular fasciitis. Some cases have very prominent osteoclast-like giant cells. That's a feature you really don't see in desmoid-type fibromatosis. So before we go on to the common spindle cell sarcomas, let's focus a little bit on solitary fibrous tumor. This is another often benign spindle cell tumor that can be a very close mimic with some of the spindle cell sarcomas we're going to focus on. Solitary fibrous tumor arises in middle-aged adults typically. It has a really broad anatomic distribution. I'm sure that many of you know that solitary fibrous tumor was first described in the pleura. For some period of time it wasn't quite clear that this was in fact a mesenchymal neoplasm. Some people thought that this might be an unusual variant of mesothelioma, but we now know that this is a mesenchymal tumor showing fibroblastic differentiation. But in addition to its very typical presentation in the pleura and lung, solitary fibrous tumor can arise in the abdominal cavity, retroperitoneum, and a pretty broad range of anatomic sites. You can really find this almost anywhere in the body. Solitary fibrous tumor is also a slow-growing painless mass in most cases, and conventional solitary fibrous tumor has a small but unpredictable risk of metastasis on the order of at most about 1 or 2% of cases. However, there does exist a malignant variant of solitary fibrous tumor. The most reliable predictor of malignancy in this tumor type is mitotic activity. And in fact, the cutoff, the threshold to designate solitary fibrous tumors as malignant is actually quite low. If you find 4 mitotic figures in 10 consecutive high-power fields, that is sufficient to call the tumor a malignant solitary fibrous tumor. Malignant solitary fibrous tumors behave in a much more aggressive fashion, quite similar to other intermediate grade sarcomas. So what are the key histologic features to help us recognize solitary fibrous tumor? People love to talk about the patternless pattern. That's the classic designation of solitary fibrous tumor. If you think that sounds a bit silly, you can instead consider it more of a haphazard architecture. It doesn't have the organized fascicular or storiform architecture of some other tumor types. Solitary fibrous tumors often have varying cellularity and prominent stromal collagen. Perhaps one of the most distinctive and helpful features to allow us to recognize solitary fibrous tumor is the presence of these dilated, thin-walled branching blood vessels that we often describe as looking like the horns of a mammal that roams the plains. These are the vessels that we now also call hemangiopericystoma-like vessels, because in the past we recognized these vessels as a feature of the tumor type that we used to call hemangiopericystoma. We now know that hemangiopericystoma in almost all cases simply represents a uniformly hypercellular variant of solitary fibrous tumor. As we'll talk about in a few minutes, hemangiopericystoma is essentially now a synonym for solitary fibrous tumor based on both pathologic observation but also the genetics of this interesting tumor type. Here's a scanning image of solitary fibrous tumor, which really nicely shows you all the features that I just mentioned. We have varying cellularity. We have these collagenous zones, much more hypercellular zones, and then these very prominent branching thin-walled staghorn vessels that you see scattered throughout the lesion. Then now we have a higher magnification view, and you can see these nondescript short spindle cells, very prominent collagen in the background, and another nice example of these delicate, thin-walled, dilated blood vessels. Just a very high-power image to see these nondescript spindle cells with very fine chromatin and indistinct nucleoli, and again, another example of the very prominent stromal collagen. This is an image that in the past would have been a perfect representation of hemangiopericystoma. As I mentioned, we now don't diagnose this tumor any longer. We recognize this as simply a cellular solitary fibrous tumor. These uniformly hypercellular examples, it really has no prognostic significance. It's really just a descriptive term. It's only those tumors that have increased mitotic activity, which sometimes goes along with increased nuclear atypia, where you have to worry about malignancy. Here, in fact, is an example of a malignant solitary fibrous tumor. Some of these tumors look very similar to spindle cell sarcomas, but here you can see that we have a pretty impressive mitotic activity. I think there's even 3 mitotic figures in a single hypera field in this case. Here's just a higher power. We have still pretty uniform and bland nuclear morphology, but a high mitotic rate. So what are the best diagnostic markers for solitary fibrous tumor? Until very recently, really the only marker we had to support the diagnosis was CD34, which is positive in almost all cases, about 95% of cases. But unfortunately, this is really a nonspecific marker. I'll come back to this in a minute. Recent studies have identified a consistent reproducible fusion gene in solitary fibrous tumor, and that is a fusion involving genes known as NAB2 and STAT6. These genes sit on top of each other on chromosome 12, and in fact this is an inversion event that results in this gene fusion. This event is, the genes are too close together for fluorescence in situ hybridization techniques to be effective in recognizing this rearrangement. But fortunately for us as surgical pathologists, it turns out that this fusion event results in very high level nuclear expression of the STAT6 protein, which is very easy to recognize by immunohistochemistry. So here's just a partial list of the other spindle cell tumors that are often positive for CD34, and you can see from this list some of these other tumor types can look quite similar to solitary fibrous tumor. This really is not a very helpful marker. Most examples of solitary fibrous tumor that are CD34 positive show very intense cytoplasmic and cell membrane associated staining, as you see in this example, although as I mentioned, about 5% of cases are entirely negative for CD34, as you see in this case. In fact, this was an example in which the gene fusion was confirmed, but the tumor lacked expression of CD34. STAT6 is positive, and as I mentioned, in almost all cases of solitary fibrous tumor. It's a remarkably sensitive and specific marker, and it typically shows very strong and diffuse nuclear staining, as you see in this example, and you find the same thing in malignant solitary fibrous tumor. So this has really dramatically changed our clinical practice really recently, just in the last couple of years. Now this is our first-line marker to support the diagnosis of solitary fibrous tumor. The differential diagnosis is fairly broad. It really depends upon the cellularity of the tumor, how much collagen is in the stroma, and I'm just going to focus on a couple of these tumor types briefly. We're going to focus on some of the spindle cell sarcomas in this table a little bit later in the hour. This is a classic scanning appearance of low-grade fibromyxoid sarcoma. This is a tumor type that Harry Evans from MD Anderson in Houston, Texas first described, and for quite some time we referred to this tumor as Evans tumor. As the name implies, low-grade fibromyxoid sarcoma typically is composed of these myxoid nodules that show this abrupt transition to these more cellular fibrous areas, as you see here. This very abrupt transition between myxoid zones and collagenous zones are very typical of this tumor type. But I think you could probably imagine in a limited sample such as this, it can be very difficult to even consider, to remember the possibility of low-grade fibromyxoid sarcoma. It's a very bland and uniform spindle cell tumor. Until you've seen an example of this tumor type, I think you probably would think this is going to be a benign spindle cell tumor. Low-grade fibromyxoid sarcoma has really no appreciable nuclear atypia. Often the mitotic rate is very low, and this is quite surprising because we now know with long-term follow-up the metastatic risk of low-grade fibromyxoid sarcoma is on the order of 40%. This tumor will often spread to the lungs and pleura, but it sometimes takes 10, 20, even 30 years after the primary tumor is excised. So it's a really big challenge for our colleagues in surgery and medical oncology to counsel these patients. We don't think of this tumor in terms of 5-year survival or metastasis-free survival. You really have to follow these patients for their entire lives to make sure they won't develop lung metastases. Fortunately, we do have a really specific marker for low-grade fibromyxoid sarcoma. That is MUC4. This is normally an epithelial mucin expressed in the colon and some other visceral organs. For reasons we do not understand, MUC4 is very highly upregulated in low-grade fibromyxoid sarcoma, and this has become an easy marker to apply to confirm the diagnosis because this marker is not expressed in the other spindle cell tumors in the differential diagnosis. Here's an example of low-grade fibromyxoid sarcoma that looks remarkably similar to solitary fibrous tumor. Perhaps it's a bit more organized in terms of its architecture, but it has a collagenous stroma, and it's a very nice example of the very delicate thin-walled blood vessels, those hemangiopericytoma-like vessels, that are a defining feature of solitary fibrous tumor, but they're not entirely specific. And as we'll come back to, we find those same blood vessels not only in some cases of low-grade fibromyxoid sarcoma, but in monophasic synovial sarcoma as well, which is probably the most difficult differential diagnostic consideration for solitary fibrous tumor. Here you see another nice example of very strong MUC4 expression. This is a very easy way to confirm the diagnosis again. Here is an example of monophasic synovial sarcoma. We'll talk about some other examples of this in a few minutes and how much the histologic overlap can be with cellular or malignant examples of solitary fibrous tumor. But fortunately, STAT6 is consistently negative in monophasic synovial sarcoma. One other tumor to consider, at least briefly, when you're encountering cases of solitary fibrous tumor. Here's a case of actually a metastasis of a cellular solitary fibrous tumor that arose primarily in the dura, in the meninges. In the past, in neuropathology, we had a diagnosis of meningeal hemangiopericytoma, which we now recognize is simply, again, a cellular variant of solitary fibrous tumor. But the dural examples of solitary fibrous tumor have a very characteristic clinical history. These patients with this tumor type will often present quite late in their disease course, 10 or 20 years following excision of their meningeal tumor, with bone metastases or liver metastases. Those are exceptionally rare sites for primary solitary fibrous tumor. So as you see in this field, if you encounter an example of what turns out to be a cellular solitary fibrous tumor in the bone, you have to ask the clinician to go back to the patient and see if the patient had a history of something that might have been called a meningioma in the past. In almost all cases, the answer will be yes, the patient did have a dural tumor, but it wasn't truly a meningioma, it was a meningeal solitary fibrous tumor. So now for the second half of this lecture, I'm going to focus on some of the most common spindle cell sarcomas. The first tumor we're going to talk about is Leiomyosarcoma. This is a sarcoma that is most often seen in middle-aged to elderly adults. It has a very wide anatomic distribution. Obviously, many of you know that leiomyosarcoma is a fairly common sarcoma to arise in the uterus, but among other extrauterine primary sites, you can find leiomyosarcomas in the retroperitoneum, within muscles of the extremities, even in the subcutaneous compartment. Interestingly, leiomyosarcomas will sometimes arise from major blood vessels, such as the inferior vena cava. That's really a classic, although quite rare, presentation for leiomyosarcoma. We know that depth, histologic grade, and anatomic site are very strong prognostic factors for leiomyosarcoma. We're not going to talk too much about grading in this hour, but I would just say as an aside that most of the large international groups of cancer groups now believe that the French grading system is probably the most valuable, and this is the system that has been adopted by the AJCC, by the College of American Pathologists, and by the WHO classification. And that's a grading system that includes mitotic rates, necrosis, and histologic type. But I would just refer you to the references I mentioned to learn about grading of leiomyosarcomas. Leiomyosarcoma has a high rate of distant metastasis. I've listed some of the most common sites here in this bullet point. In fact, leiomyosarcoma is the most common sarcoma to metastasize to the skin. The most common site is the scalp. So if you find a very sharply circumscribed focus of leiomyosarcoma in the dermis, you have to consider the possibility that that is a metastasis from the uterus, retroperitoneum, or other deep soft tissue sites. Primary atypical smooth muscle tumors of the dermis usually have a much more infiltrative, kind of nodular architecture. They're not really sharply circumscribed as are metastases to the skin. The key features of leiomyosarcoma are pretty easy to talk about because I'm sure that you all are quite familiar with the features of smooth muscle tumor cells. Leiomyosarcomas almost always show a fascicular architecture, similar to what we talked about with Desmoid type fibromatosis. But the cytology is really distinctive, and this is the most helpful feature to recognize leiomyosarcoma. The tumor cells are spindled in most cases, and they have very bright eosinophilic cytoplasm. The nuclear features, even if they're present quite focally, can be a helpful clue to the diagnosis. The classic cytology of leiomyosarcoma includes nuclei that are very broad and blunt-ended. People often like to describe them as looking like cigars. That's a kind of a classic tag phrase for the nuclei of a leiomyosarcoma. And unlike many other spindle cell sarcomas, you often get a sense of the cell borders between the tumor cells of leiomyosarcoma. And I'm sure you're all familiar with the immunohistochemical findings in this tumor type. Unfortunately, we don't have any really modern kind of molecular correlate markers as we're talking about through this hour. Smooth muscle actin and desmin are usually diffusely positive, although these are not very specific markers. They're also expressed in myofibroblastic tumors and skeletal muscle tumors. The most specific marker in this list is caldesmon, also known as heavy or H-caldesmon. Caldesmon has a little bit less sensitivity to leiomyosarcoma than smooth muscle actin and desmin, but the specificity is considerably higher. Really, the only other tumor type to consider that is also positive for caldesmon is gastrointestinal stromal tumors. Gastrointestinal stromal tumors are caldesmon positive in about 2/3 of cases, so that is a potential diagnostic pitfall. Here's a classic histologic example of leiomyosarcoma. We have these nice intersecting fascicles of spindle cells, and even from this example, I think you can appreciate the very bright cytoplasmic eosinophilia, which is a really reproducible finding in leiomyosarcoma. Here we look a little bit more closely, and you can nicely see the classic cytologic features that I talked about. When you see these tumor cells in longitudinal section, you see they're quite broad and they have these rounded edges. The broad nuclear morphology with the blunt ends is a very typical feature of leiomyosarcoma. And in this example, we see these very thin eosinophilic lines between the tumor cells, and again, those are the sharply defined cell borders that are a very characteristic feature of leiomyosarcoma. Some examples are less well differentiated. This example has much more striking pleomorphism, some bizarre mitotic figures, but it still retains that bright eosinophilic cytoplasm that's typical of leiomyosarcoma. And in some cases, the degree of pleomorphism can be so great that your differential diagnosis would not be with the other spindle cell tumors, but it would be more with the pleomorphic sarcomas, which we're not going to talk about so much today. And here's just an example of very strong and diffuse smooth muscle actin and desmin expression, which is very typical for leiomyosarcoma. So the differential diagnosis for leiomyosarcoma is probably not quite as broad as it is for some of the other spindle cell tumors. I am going to focus on the first three examples here in some detail. Benign leiomyomas of deep somatic soft tissue are exceptionally rare. Really, if you see a smooth muscle tumor in deep soft tissue of the limbs or the trunk wall, you don't want to find any mitotic activity. If you find really even only one or two mitotic figures in that anatomic context, it almost certainly represents a low-grade leiomyosarcoma. The situation is a bit different in the retroperitoneum and pelvis of women. There does exist a benign leiomyoma of those anatomic sites that we refer to as uterine type leiomyoma, and they really have an amazing analogy to fibroids, to leiomyomas of the uterus. You can find mitotic activity at that anatomic location in women. However, if you're dealing with a morphologically well-differentiated smooth muscle tumor in the retroperitoneum of men, similar to somatic soft tissue, you really don't want to find any mitotic activity. Again, if you do, it probably represents at least a low-grade leiomyosarcoma. One other tumor to briefly talk about is angioleiomyoma, so-called vascular leiomyomas. And the reason to focus on this tumor is because these tumors arise in the subcutis. We already talked about how you can find true leiomyosarcomas of the subcutis as well. Because angioleiomyomas can have a little bit of nuclear atypia, they can have an occasional mitotic figure, if you don't recognize the perivascular orientation of the tumor cells, it's not so difficult to mistakenly diagnose leiomyosarcoma in that setting. Here are some examples of benign leiomyomas of deep soft tissue. So here's an example that has a very large area of coarse dystrophic calcification, which is pretty typical of deep leiomyomas. The nuclei are very bland and uniform. Here's an example of a uterine type leiomyoma from the retroperitoneum of a woman. Very bland, uniform nuclei, eosinophilic cytoplasm. And as you see in this case, some of these tumors have this kind of plexiform, somewhat hydropic appearance, very similar to their counterparts in the uterus. Going to high power, again, we find the very bland, uniform nuclei. We really don't like to see any atypia or pleomorphism in tumors at these sites. I think that it's a little dangerous to consider these symplastic or atypical leiomyomas. Your threshold in that setting should be much lower to consider those leiomyosarcomas. Here's another example of a benign retroperitoneal leiomyoma. No nuclear atypia to speak of. They really look like very well-differentiated smooth muscle cells, and there's almost no mitotic activity in this case. Here's a couple of slides, examples of angioleiomyoma, vascular leiomyoma. It's another well-differentiated smooth muscle tumor with really abundant eosinophilic cytoplasm. But from this field, you can nicely see how we have perivascular orientation of the smooth muscle cells around these thick-walled vessels. That's the way we recognize angioleiomyoma. And here's just one other example. Similar to the previous image, you find the perivascular orientation of these smooth muscle cells. Just a couple quick images of low-grade myofibroblastic sarcoma. I've alluded to this tumor a couple times already in this session. In contrast to leiomyosarcoma, low-grade myofibroblastic sarcoma typically has less abundant and less densely eosinophilic cytoplasm. The nuclei are somewhat more tapered and delicate. They don't have those broad, blunt-ended nuclei that are typical of leiomyosarcoma. And at the periphery of the lesion, you often find this really impressive infiltrative margin into the skeletal muscle. One of the most common sites for low-grade myofibroblastic sarcoma is the head and neck, especially the tongue. This is in fact an example of low-grade myofibroblastic sarcoma infiltrating into the skeletal muscle of the tongue. Leiomyosarcomas are usually quite well circumscribed, so they'll kind of push aside the soft tissues next to the tumor as they expand. I want to just mention very briefly a couple words about fibrosarcoma before we move on to the last two common types of adult spindle cell sarcomas we're going to focus on. So as many of you know, fibrosarcoma used to be a very common diagnosis in the past several decades ago, but we now know with contemporary criteria we are able to reclassify almost 100% of cases of the tumors we used to call fibrosarcoma. These tumors are almost all monophasic synovial sarcomas, malignant peripheral nerve sheath tumors, malignant solitary fibrous tumors, and in tumors that arise in the subcutaneous tissue and skin, we have a higher grade variant of the very well-known cutaneous tumor, dermatofibrosarcoma protuberans, which we refer to as the fibrosarcomatous variant or fibrosarcomatous transformation of dermatofibrosarcoma protuberans, DFSP. We do have some distinctive tumors, sarcomas, that we believe show fibroblastic differentiation, but these tumors, with the exception of infantile fibrosarcoma, really don't have morphology that looks like the classic fibrosarcoma. We're talking about some of these very briefly today, but these are somewhat different histologic patterns to what we're focusing on. So I could show you this image. Here's 4 nice examples of tumors that you might have called fibrosarcoma. I think when I say the word fibrosarcoma, most of you have a very good conception in your mind of what it should look like, and it really looks like this. We have a very blue fascicular spindle cell sarcoma, very tight intersecting fascicles, limited amounts of cytoplasm, but of course none of these are truly fibrosarcoma. This is all the tumors I just alluded to. We have synovial sarcoma, MPNST, malignant solitary fibrous tumor, and fibrosarcomatous DFSP. A couple more words about DFSP. Here's a classic example of DFSP. We have this dermal-based mass. You can see it's really diffusely involving the dermis and growing into the subcutaneous tissue in this classic storiform growth pattern. This is a really classic morphology for DFSP, and it's a helpful clue to the diagnosis. You'll often find these linear arrays of fat cells that are left behind as the tumor infiltrates right through them. When you look on higher magnification, you find that very diffuse infiltration and very strong expression of CD34. In its classic form, DFSP has this very tight whorled or storiform architecture as you see on the left. In contrast, when it transforms to the fibrosarcomatous variant, the tumor acquires this fascicular morphology. That fascicular architecture defines it as a fibrosarcomatous DFSP. So now we're going to move on to synovial sarcoma. This is a sarcoma type that most often arises in adolescents and young adults, although you can diagnose synovial sarcoma in the elderly. For some reason, elderly patients sometimes will get synovial sarcomas in the lung and the pleura. Synovial sarcoma also has a broad anatomic distribution. It was first recognized in the vicinity of the knee, and that's why the first pathologists who recognized biphasic synovial sarcoma believed that this tumor had a relationship to the synovial cells. They thought that the glandular component of biphasic synovial sarcoma looked very much like synovial cells. And in fact, we all now know that this is a misnomer. Synovial sarcoma has no relationship whatsoever to the synovium. Synovial sarcoma will sometimes show very prominent calcifications, which on imaging can be a helpful clue to the diagnosis to our radiology colleagues. Synovial sarcoma has a high rate of recurrence and metastasis. When it metastasizes, it often spreads to the bone and the lungs. Synovial sarcoma is one of the other chemosensitive tumor types, so this is an important diagnosis to make properly. So let's focus on some of the key histologic features. Synovial sarcoma is composed of very uniform tumor cells. If you see pleomorphism in a tumor when you're considering synovial sarcoma, it's almost impossible for that to be a synovial sarcoma. Much less than 1% of synovial sarcomas have pleomorphism, despite the fact that this is an aggressive sarcoma type. These tumor cells are usually arranged in very tight fascicles. They have these overlapping nuclei. It looks kind of purple from low power. You'll sometimes find this very bright, wiry stromal collagen fibers between the tumor cells. And as I mentioned earlier in the session, branching staghorn vessels, very similar to solitary fibrous tumor, are a very common feature of synovial sarcoma. Here are some examples of monophasic synovial sarcoma. This nicely shows us the very uniform nuclear morphology. There's really no pleomorphism to speak of, but they're very closely opposed and overlapping nuclei with very limited cytoplasm. Here's an example where you can appreciate that wiry stromal collagen fibers that I talked about. That can be a very helpful clue to the diagnosis of synovial sarcoma. And here's an example of a synovial sarcoma that has these staghorn blood vessels very similar to solitary fibrous tumor. That's probably the most challenging tumor in the differential diagnosis with synovial sarcoma. Here's another example, which I probably could have told you this is a cellular or malignant solitary fibrous tumor. It looks almost identical, uniform nuclear morphology, and those similar dilated branching blood vessels. As many of you know, excuse me one moment, so here we have coarse calcifications in synovial sarcoma. As I was just about to mention, many of you are probably aware of the fact that we do have a poorly differentiated variant of synovial sarcoma, which is composed of much more rounded cells. So the differential diagnosis for this variant is much more along the lines of a round cell sarcoma. One of the good clues to the diagnosis, again, is the presence of these hemangioparasitoma-like vessels. You don't see those in most of the other round cell sarcomas. When you look under high magnification, again, these are much more rounded nuclei. It looks very much like a Ewing sarcoma, for example, with very uniform nuclear morphology. So what are the diagnostic markers of synovial sarcoma? I'm sure most of you are aware of the fact that epithelial membrane antigen and keratin are typically positive in synovial sarcoma. This is an unusual sarcoma that shows true epithelial differentiation by immunohistochemistry and by electron microscopy if you examine those tumor cells. EMA, although it's positive in most cases, is often sort of patchy or weak. Keratin, when it's positive, it's usually just a few cells in the spindle cell examples of synovial sarcoma. Unfortunately, S100 protein is positive in about a third of cases, so this marker is not helpful to separate monophasic synovial sarcoma from malignant peripheral nerve sheath tumor. This is one of the first sarcomas for which a translocation was identified, the classic X18 translocation involving the genes that are now known as SS18 and either SSX1 or SSX2. This used to be called SYT, but it's been renamed SS18, which it shouldn't be too hard to remember. It's synovial sarcoma 18, and you remember the X18 translocation of this tumor type. There is a more recently developed marker by immunohistochemistry, that is TLE1. This was first discovered by gene expression profiling. I'll come back to that in a minute. Here's EMA expression in synovial sarcoma. This is quite a lot of expression, more than some cases. And here is the classic translocation of synovial sarcoma. We have the X18 translocation, and helpfully we have these black arrows here to indicate the translocation. But it's very easy to confirm the diagnosis by FISH. You can do FISH and paraffin sections. Most laboratories that run paraffin section FISH are going to be able to evaluate for the possibility of the SS18 rearrangement of synovial sarcoma. And here we're looking for a separation or a break apart of the 5' and 3' probes. So here we have the red and the green that are separated as opposed to the normal copies which are overlapping. So unfortunately, although TLE1 was sort of briefly thought to be a highly specific marker for synovial sarcoma, we now know that about 20% of malignant peripheral nerve sheath tumors are also positive for TLE1, and sometimes that can be quite diffuse. However, this is such a sensitive marker, I think that's probably the most helpful application of TLE1. If you have a tumor and you're considering synovial sarcoma, if TLE1 is negative or very weak and focal, it's unlikely to be synovial sarcoma. But again, unfortunately, the specificity is not perfect. Most cases, as I just mentioned, are very strongly positive. Here's a synovial sarcoma with very strong nuclear TLE1 staining. And here's just another example of the poorly differentiated synovial sarcoma with the same strong TLE1. So just a couple words about differential diagnosis. We've already talked about solitary fibrous tumor, and we're going to come back to malignant peripheral nerve sheath tumor in the last few minutes as our final tumor type we're going to discuss. So here's an example of malignant peripheral nerve sheath tumor with some TLE1 expression. Most positive cases are going to show very weak nuclear staining where it looks quite different from that strong and diffuse staining we saw in monophasic synovial sarcoma. But as I mentioned, some MPNSTs can show strong TLE1 as well. And here's just one slide of a spindle cell rhabdomyosarcoma. I think this tumor looks probably more similar to a Leiomyosarcoma than it does to a synovial sarcoma. This is a tumor type that is fascicular, a high degree of nucleotypia, and these tumor cells are very strongly positive for Desmoid, similar to Leiomyosarcoma, but they will also express these skeletal muscle transcription factor markers, myogenin and MyoD1. So finally, we're going to spend the last few minutes talking about malignant peripheral nerve sheath tumor. This is a spindle cell sarcoma that arises most often in middle-aged adults. Paraspinal location is quite typical, although the tumors also arise in the extremities. About 50% of malignant peripheral nerve sheath tumors arise in patients with type 1 neurofibromatosis. The other 50% are sporadic. This is one of the spindle cell sarcomas that arises following therapeutic radiation therapy. In fact, about 10% of malignant peripheral nerve sheath tumors overall arise following radiation. Patients with NF1 have about a 7 or 8% lifetime risk of developing a malignant peripheral nerve sheath tumor. This is another aggressive sarcoma with a high rate of metastasis, and recent studies from the French sarcoma group suggest that grading MPNST may be helpful to predict the development of metastasis. So when a malignant peripheral nerve sheath tumor arises in a patient with type 1 neurofibromatosis, or when it arises from a large nerve or from a pre-existing neurofibroma, the diagnosis is relatively straightforward. We always assume a spindle cell sarcoma in a patient with NF1 is a malignant peripheral nerve sheath tumor. But without these associations, this is a very challenging diagnosis to make. Some of the key histologic clues to the diagnosis include alternating hypocellular and hypercellular areas. This marbled appearance is very typical of malignant peripheral nerve sheath tumor. You'll often find at least focal areas with myxoid stroma, and perhaps the most helpful clue to the diagnosis is the perivascular accentuation of cellularity, as I'll show you in a moment. You can find heterologous elements in MPNST. About 10% of cases will show other lines of differentiation. Most commonly, it's skeletal muscle differentiation, and we often refer to malignant peripheral nerve sheath tumors with heterologous rhabdomyoblastic differentiation as malignant triton tumor. Here's a very typical example of that somewhat marbled appearance of MPNST with these cellular fascicular areas alternating with somewhat more myxoid areas. Here's another example of MPNST with that same alternation of hypercellular and somewhat less cellular areas. Some examples are really fairly nondescript, just looks like a spindle cell sarcoma with these delicate tapering, somewhat wavy nuclei. A high power, this tumor could very easily be mistaken for Leiomyosarcoma, perhaps monophasic synovial sarcoma, as we'll come back to in a few minutes. Here's another example with these delicate tapering wavy nuclei, which are typical features of the Schwann cells that make up malignant peripheral nerve sheath tumor. And here's an example of that perivascular accentuation of cellularity. That perivascular growth is quite typical of malignant peripheral nerve sheath tumor and can be a diagnostic clue. Here's an example with heterologous skeletal muscle differentiation, which you can often recognize even on the H&E. We have these very bright pink rhabdomyoblasts, which you can also highlight by immunohistochemistry for Desmoid or myogenin, as you see in this example. So unfortunately, the markers we use to attempt to demonstrate Schwann cell differentiation in malignant peripheral nerve sheath tumor are only positive in 40 to 50% of cases, and I've just listed them here. S100 protein and SOX10 are probably the best markers, but again, fewer than 50% of MPNSTs are positive. But fortunately, in the last couple of years, we do have a very interesting new diagnostic marker that's been developed. That is H3K27ME3. I must say I had to repeat this over and over again a few times before I could pronounce it properly. I'll come back to the meaning of this in a moment. So here's a rare example of MPNST that showed quite extensive S100. When SOX10 is positive, it's usually just a few scattered nuclei. So I have to very briefly mention the polycomb repressive complex. This is a complex that's involved in chromatin regulation. For transcription to happen, this complex is recruited to histones, and it trimethylates histone 3 at the lysine 27 residue. And that's a critical part of our transcriptional regulatory machinery. So it turns out that almost 90% of malignant peripheral nerve sheath tumors harbor mutations in one of the genes that encodes this polycomb repressive complex. When you have biallelic mutations in this gene, then this enzyme complex can no longer trimethylate histone 3 at lysine 27. So about 2/3 of MPNSTs overall will show a loss of this trimethyl mark, and I'll show you that stain in just a moment. The rate of H3K27Me3 loss depends on grade, and this fortunately is a very specific diagnostic marker. In this table, you can see data from a study that we published a few years ago, as well as a study from Christina Antoniescu's group at Memorial Sloan Kettering Cancer Center in New York. High-grade MPNSTs, which are those that are most commonly encountered in our clinical practice, about 90% will show loss of staining with this trimethyl mark. Unfortunately, as I mentioned, pretty much all the other spindle cell tumors in the differential show retained staining for this marker. Here's an example where you see loss of expression of H3K27Me3. We always have an internal control in the form of endothelial cells and stromal cells, but we're looking for loss of staining. And here's just one other example with a tumor that had a lot of histiocytes between the tumor cells, but we have loss of staining in the tumor cell nuclei. So we've already focused on many of these tumors in the differential diagnosis, so I'm just going to go quickly through these in the last few minutes. So here's a synovial sarcoma, which can look very similar to MPNST, but fortunately synovial sarcomas show consistent normal nuclear staining with H3K27Me3. As many of you know, cellular schwannomas can be somewhat difficult to recognize. They lack the myxoid hypocellular zones of typical schwannomas. If you're lucky, you'll find areas that have the perivascular hyalinization, a very good clue to the diagnosis of schwannoma. And even classic schwannomas can sometimes have quite considerable nuclear atypia that we refer to as ancient change, degenerative atypia in the schwannoma. In contrast to MPNST, schwannomas are strongly and diffusely S100 positive. And here's a cellular schwannoma which always shows that normal pattern of staining with H3K27Me3. Neurofibromas also might be confused with MPNST, especially the cases that have occasional atypical nuclei, the so-called atypical neurofibromas, which can have the same degree of degenerative atypia you can find in ancient change in schwannomas. But I think a very challenging tumor to potentially mistake for MPNST is spindle cell melanoma. If you don't have an in situ component, this tumor could easily be mistaken for a malignant peripheral nerve sheath tumor. Spindle cell melanomas will sometimes have a little bit of more packeted architecture, more epithelioid morphology, and strong and diffuse S100 and SOX10 is almost always seen in spindle cell melanoma, and as I mentioned, you really will never see diffuse staining in MPNST. Spindle cell melanomas are usually negative for HMB45 and MART1, which is why we sometimes struggle with this distinction. But fortunately, H3K27Me3 is positive or retained in spindle cell melanoma. So my last few points before I close, pay close attention to histologic features. Are the tumor cells uniform? Is there pleomorphism? Look at the architecture. What is the quality of the stroma? Once you have a differential diagnosis, apply immunohistochemistry judiciously. We're fortunate to have these really specific new diagnostic markers based on genetics, and use molecular diagnostic testing when needed, especially to confirm synovial sarcoma. Thank you.
Please submit your questions by selecting the chat pod located in the lower left corner of your screen. Then type and send your question. And I see we do have one question, Doctor.
Great. So the question is, when do you call a subcutaneous thigh mass that is a smooth muscle tumor with focal nuclear pleomorphism but no necrosis or mitoses? You know, do we use the term uncertain malignant potential, or do we call it a Leiomyosarcoma? So I think that can be a really challenging situation. If it's a relatively superficial tumor, if you look carefully at the nuclear morphology, sometimes that's actually going to be degenerative atypia. If the chromatin is kind of somewhat smudgy, if you find nuclear pseudoinclusions, we consider that to be degenerative. However, if you think it's bona fide, coarse chromatin nuclear atypia, those are almost always leiomyosarcomas. I really don't like to use the term uncertain malignant potential for smooth muscle tumors. I think we have to, outside the uterus that is, I think we have to look very carefully for mitotic activity. If you really can't find any, I sometimes will keep those as a descriptive diagnosis. I'll call it an atypical smooth muscle neoplasm, and in a comment I might say that it's sort of best regarded as a low-grade leiomyosarcoma, but honestly there are some cases in which that distinction is really difficult.
Well,
Any other questions?
I see we do not have any other questions at this time.
I would just say that I'm very happy to answer any questions offline. As you see from the slide deck here, my email address is included, so please feel free to email me later on if you have any questions about the talk or anything about soft tissue tumor pathology in general. I would be very happy to answer your questions. And thank you again for participating in this webinar.
Yes, we would like to thank everyone for joining our program today. A link to the survey is now displayed on your screen. Please take a few moments to complete and submit the survey. We appreciate your feedback. This concludes today's webinar. You may now disconnect.